turn the equipment
All right.
on. And
did everybody else get booted off, or just me?
Just you.
no,
All right. So there's something with this computer. I'm so sorry. If I drop out, I'll try and hop on with another computer.
okay.
Okay.
All right.
This is the
Yeah. Go ahead, Len.
I'm going to reduce the window, minimize that window. So after she had done the application with the BodyLENS, the eye emerged 1/4 inch further out in a line with the other eye. And I think that is totally unexpected. And one of the things that I love about the BodyLENS is that it oftentimes generates results that are so unexpected. And there really is no sensation to doing this. You have the electrodes on, you turn on the equipment, and after a certain number of seconds, it stops. And then most of the time, the pain is either sharply reduced or it goes away. And when it doesn't go away immediately, it'll go away or be sharply reduced within 24 hours.
Wow.
And that's from one application. So it is surprising, and there's no stimulation, there's no voltage or current put into the person that's measurable with any common device, a voltometer. One of the biggest reactions from the people connected to the equipment is some consternation. And that is about, they want to know where their pain went. They want to know why it went away. They want to know where it went. There was one time I did a training in New Orleans, and at the end of the training, the woman was sitting on her ankle, and she said in her southern voice, she said, "I hope you realize that for 3 days I've been trying to make my hip pain come back, and it was unbearable at the start, and I still can't make it come back." So here's a person who is so concerned about where the pain went, and probably did it really go away, that she's been trying to make it come back for 3 days, and she failed. So this kind of flies in the face of all the theoretical beliefs that chronic pain is centrally mediated by the brain, because if you put the electrodes over a body spot instead of on the head, where's the central mediation from the brain in this? Now, I told a favorite physician this, and he said, "Well, the body talks to the brain." I said, "Yeah, but that's not the most economical theorizing to do. It's not the most parsimonious. It's not the simplest possible explanation. A better explanation might be that throughout the body there is a web of certain kinds of cells that are similar to what's already in the brain. And this web of cells throughout the body, and there's some evidence to this, are composed of neurons, astrocytes, or glial cells, and endothelial cells, or blood vessels. And I think that amongst those three types of tissues, they can actually constitute another kind of tissue in the body. Now, the blood is considered to be a tissue, even though it's made of a loose bunch of blood cells that float around through the arteries. It's considered to be a tissue. So I don't see why, if the blood is considered a tissue, why this triad of cells consisting, again, of the astrocyte or glial cell, the blood vessel cells, and the neurons, could not be considered what kind of tissue. They may have all the kinds of memory and logic functions that will perpetuate pain so that the pain becomes chronic. Now, it may be useful to you if you have an idea of what I consider the mechanism of these self-perpetuating issues to be. Now, whether it's chronic cognitive dysfunction seen after head injury, or mood dysfunction, or whether it's chronic pain, I believe that there are two general and related mechanisms. One is that the brain and the body are very much afraid of seizures. And I'm anthropomorphizing a bit, but oh well. So what the brain does, and this is just about the brain, is that it begins to shut down its connectivity. And it shuts it down because it can discharge inhibitory neurotransmitters into its own tissues, like GABA. And it's an oddity in evolution that once this kind of a shutdown starts to happen, it continues and literally cannot stop under most conditions unless the person actually is a mutant and has evolved a way to stop those reactions. And the reason I think that there aren't more people who can do that, and there are people who don't use our services, they become traumatized through many avenues, and they just go on, they say, I don't worry about it. These people have evolved mechanisms to reverse those disconnectivities. And what the function of the lens is, by the use of very complicated feedback, is basically to confuse those areas of the brain, and only those areas of the brain, that are linked together, perhaps through what Thatcher says is true, with the phase locking that happens in many situations, so that the lens signal, whether it's on the head lens we call the classic lens, or the body lens with chronic pain, it disturbs and perturbs those areas, and it releases the phase locking so that the cells can once more connect to each other. And once the process of reconnection starts to happen, and this is without any intervention from the lens whatsoever, body lens or classic lens, then the connectivity becomes more and more and more established. And the person gets more and more competent as the connections are made of the brain to itself, of the body to itself. Now, there's another related mechanism to this, and that is, let's say that the person is constitutionally or otherwise has impaired circulation to the brain. I think the same kind of mechanism that causes vasoconstriction in the brain or in the body with vascular pain can happen. And the lens, whether it's body lens or classic lens, will shake up that suppression on the vasculature or the neurology. In other words, reset the phase relationships And then the brain can relink and the body can relink with itself. And the connectivity is once more reestablished. So this is the most plausible way to look at the body lens or the other lens, classic lens, I think, after having worked with these issues for, 35 years, and having done standard neurofeedback and standard biofeedback, all kinds, for 15 years before that. So that's the basis of my clinical observations on the kind of speculation and hypothesizing that I've done. And there are different kinds of processes, these subjective awarenesses that get initiated by the lens, whether it's body lens or classic lens. And they come down on the side of, is it primarily neurological or is it primarily vasculature? Now, it's an interesting kind of an issue, this vasculature, invoking the vasculature. Between the EEG electrodes and the brain are vascular beds. And it's really funny to me that people don't talk about those vascular beds. They only talk about the neurology, and the maps are about the neurology. Now, it may be true that we don't really know how to quantify either vascular impulses or glial impulses, but why the vasculature and the glia should be ignored as operative tissues in neurological dysfunctions is beyond me. So I think it makes good sense to think that both the lens and the body lens can dilate the blood vessels, and people will report that they feel warmer after a session, the lens session or body lens session. Just as they'll talk about being cognitively more competent after a body lens session, when the electrodes had been placed nowhere near the brain. I remember Kathy again, head of OchsLabs, once put the electrodes on a guy's elbow. Now, he had been in golf practice all day long with his son who just turned 21, and he really wanted to keep up with his son and show him who was man. So at the end of the day, his elbow was hurting. He had tennis elbow. And Kathy put the electrodes, and he was in a foul mood. So Kathy put the electrodes on his elbow, gave him a few seconds, maybe 109 seconds of body lens on the elbow. And within 3 minutes, he was back in the kitchen again, whistling and humming, cheerful. So here we have not only a total absence of elbow pain, but a change in mood and cognition. His outlook on life was much brighter. He was able to function again. And that's after 109 seconds. No daily wearing of a TINS unit, no long 20-minute sessions. Now, they can happen. A long 20-minute session can happen if you have a patient who is appropriately anesthetized and they can't sense anything physically. They're in their heads all the time, and their body is just something to carry their brain around. So, you know, for people who have this degree of anesthesia, yeah, you will on occasion need longer sessions. But for most people, they don't. 109 seconds can take care of a lot of people and be responsible for post-surgical pain that's lasted years, and a physician to go away completely after a few sessions. Or was it one session? I don't know offhand. But it was either one or the other. Kathy asked the physician, how's your pain now? And the physician said, you mean like gone? So this is interesting. So it calls into question, I think, again, all the theorizing about pain, chronic pain being centrally mediated. And I have no problem with being wrong. I've been wrong a lot before. And if this wrong hypothesis stimulates research, I'm good with that. I don't mind being wrong. So that's the ballpark of what I really wanted to say. What kinds of questions do you have?
Hi, this is Rick. You're talking about a lot of physiology, and so I'm a physiologist, not a practitioner.
Okay.
And so, just a few observations. So what you're talking about, of course, much of it is based in basic physiology. So, for example, repeated stimulation of a pain pathway is known to sensitize the pain pathway. And where this is studied the most with migraine headaches, and it's a chemical phenomenon. Just like pain is a chemical phenomenon, the old idea used to be that you had to damage tissue to get pain, and it's not true. That, yes, damaged tissue releases chemicals, which are analgesic compounds that stimulate pain receptors and pain pathways, but you can have spontaneous release of these chemicals and also produce pain without any tissue damage. And the sensitization process occurs, for example, in migraine through a chemical called CGRP, calcitonin gene-related peptide, associated with the trigeminal nucleus in the brain. So that's just one observation. Another observation about what you're saying, and of course I'm not questioning that you have some good hypotheses here, but to base it in the fundamental physiology would be helpful. And so, for example, the placebo effect is well known. And in the placebo effect, we now know that we can block the placebo effect in pain with naloxone. That naloxone blocks opioid receptors. And our body has an endogenous opiate system. In fact, our body also has an endogenous cannabinoid system to release its own cannabis, and called anandamide. And the opiates, endorphins, and enkephalins in the brain are well known. So if you block those receptors with naloxone, it turns out that the placebo effect goes away. So we think that the placebo effect is due to release of real neurotransmitters and hormones and chemicals that are stimulating these processes, just like sensitizing a neural pathway by continuous pain. In other words, you keep stimulating, and it sensitizes. That means it lowers the threshold of the neurons that are involved in that pathway to further stimulation, and it becomes almost automatic to have the pain. Anyway, so if you can, what you're saying about the glial cells and the connections, they're likely to be in the spinal cord, for example, as well as the brain. And there may be clumps of them that are kind of operating like you're talking about, and they're releasing real chemicals. So these are fundamentally chemical phenomena, the way I look at it, that are stimulating the electricity.
Could well be. It's wide open as far as I'm concerned.
I have another question. This is Martin. I'm interested I'm a biologist, human biologist. I'm interested in the energetic system you are actually applying for one reason. I have two concerns with the theory that the pain is actually produced locally by only on certain locations of the body, sheer by the fact that there is such a thing as phantom pain. So people losing limbs and they still produce the hurt. Right. If that pain would be produced locally only, then that pain would not be possible. And there is another input I would like to make. The body is equipped with a communication system which is particularly designed to be electromagnetic. That's the cardiovascular system. This is a communication line which combines all cells. That would explain why you can have an effect on the brain by measuring local inputs. So I would be very, very interested if you could just quickly lay out the basics of the feedback mechanism technically. What is LENS doing?
Well, I can tell you that. The lens only provides, it measures the dominant frequency as it changes on a moment-to-moment basis. And it provides, as I said, a very complex feedback signal, which is a function of that dominant frequency. But that signal is both alike and unlike the dominant frequency that is picked up.
Yeah, that's the modality. But technically, by what means are you providing the feedback signal?
Oh, you just attach the electrode to the skin.
Now that's just measuring. Now,
No,
you need to feedback something in order to have an effect. What are you feeding back?
You're confusing feedback to the eyes and ears with feedback to the skin. I'm saying that this is the only feedback mechanism we have. There is nothing to watch. There's nothing to listen to.
No, but apparently you just measure something. You don't feed something back. Do I get that correctly?
It's measuring something. We send up the wires to the electrodes.
So there is absolutely no energetic feedback brought back to the body.
Nothing that can be measured by ordinary equipment.
But there is something. There is something you feed back, right? It must be, or else it's not feedback.
There's a signal, and it reminds me of the days when we used flashing lights. The engineer said the current flow in the wires to the glasses lights, the LEDs, is down to 0.006 microamps of current.
Yeah, but you do. What I'm interested in, what's the kind of feedback? Is that an electromagnetic signal? Is it a sound? Is it sound? It's not. I know that, and it's not light. So, but it's an electromagnetic signal. Even so minutely weak that regular instruments don't measure it. Is that correct?
No, I'm good with that. That is a speculation on that.
So yeah, but what's the feedback then?
It's a frequency in hertz that varies with the dominant frequency.
In what form? Electromagnetic or what form is that frequency provided in?
Really measurable with a voltmeter or an ammeter. I'm guessing it's electromagnetic.
Okay. That was the primary question, because that would explain how signals are actually transported throughout the body to the brain in liquid. You know that the frequencies the brain operates in are electromagnetics are very special. Frequencies above 300 hertz have big troubles to travel in a liquid frequency. That's why submarines can't radio communicate with the land in water, in salt water. So frequencies that are slower travel very well in a saline or in a liquid containing ions. And blood is nothing but that. It's not only a tissue. It's an extremely efficient internal communication line of electromagnetic signals that travel at the speed of light. That would explain. I mean, there's no question that you have absolutely miraculous effects, but the mechanism of it is very possible still electromagnetic. I mean, a electromagnetic signal of an absolutely unmeasurable size already triggers epigenetic events in a cell. And these signals go everywhere in the body, so it can have an extremely harmonizing effect. Keep in mind, there is a reason why the brain produces radio waves, not just for us to play around with. It's a big effort to produce them. Why does nature evolve such a thing? It's a signaling process. Now, by introducing these signals, you can have an extremely great effort if you're not too strong. Does it make sense?
The signal has been measured my Lawrence Livermore Labs is 10 to the minus 28 watts per square centimeter.
Which is still enormous compared to the single production, electromagnetic production of a single cell.
Okay.
So I'm saying that supportively, not critically. We don't need to have a atomic power plant to have an electromagnetic effect on parts of the body.
Sure.
It's very subtle. And the equipment doesn't measure it, yes. But that's the problem of the insensitivity of the equipment.
Right.
But
We have to have a Faraday cage used for testing digital watches in order to get it quiet enough in the room.
yes,
Signals. So in a way that the signals were not drowned out by radio waves, from stations, transmissions.
absolutely. But here you have the inverse effect. It's actually internally, inside the cage. If you would say the skin represents, and it does so to a certain degree, a Faraday cage.
Mm-hmm.
Hello, this is Donald from Detroit. I just wanted to say hi, Len.
Hey, Donald, how are you?
I am well. I'm not as smart as these guys.
You know this work, don't you?
Well, I'm sorry?
You know that this stuff does not work.
This stuff is absolutely beautiful, and the magic is still happening. I think I may be the only person on this webinar that actually is using Lens. I don't know if anybody else is, but the magic is still happening, Len.
Well, that's
and
great.
I have focused mostly on autism, and whatever the mechanism is, I don't try to explain it to people. Maybe I'll send them to Martin. I don't know, and or you, but the magic is still happening, and it's been a joy. It's been one of the most exciting things I have done in psychology, along with the other neurofeedback, the traditional as well. But yours has really been separate. I'm sorry. I can't hear you.
Have you used BodyLENS?
I have not. I kind of, I'm on the listserv, and you know me, I'm kind of conservative. I like to stay in my scope of practice. But after tonight, I think that's going to change a little bit. I mean, I still work as I have my alternative practice, but I've joined another clinic doing more. I've got caught up in doing more of the traditional neurofeedback. That's for Dr. Suter, and the crew here has helped me out immensely. But I have not. I have not even. As a matter of fact, I just heard of it for the first time a few months ago that somebody came up to me and started talking about it. So it's again, Len, it's a new. It's fascinating, absolutely fascinating.
It is within the scope of your practice.
I'm sorry?
Pain management is within the scope of your practice.
Well, maybe. I don't know. Some people would beg to differ, and so many good things are happening right now, But again, I wasn't shy. I didn't wait 12 years ago when I started with you. Someone said, "How do you know what this lens thing is going to do? How do you know? Have there been enough studies?" I say, "You know what? If I wait for the studies, I could wait forever." So I probably will jump in, Len.
Hey, Donald, it's Rob. And Len, I'm sorry that I was going in and out. My computer was acting up. But while Donald's on this topic, I wanted to ask you if you're open to other questions about lens in general and not just lens body talk.
Sure.
Okay. So for those that here have other questions for Len, about either lens, the neurofeedback equipment or the body talk, feel free to ask them. And Donald, I would agree with Len. If you're looking at self-regulation as an issue for management of pain, then you are within the scope of your practice if you're focusing on self-regulation.
Okay.
I want to say hi to Len. This is John Hummer. Can you hear me, Len?
A little bit fuzzy, John, but we can hear you.
Yeah. I just wanted to say hi to Len, and I had one question I wanted to ask you, Len. I still have LensWare 1, so I'm still back in the old school there. But I just had a technical question. Do you include the infraslow frequencies of 0 to 1 hertz in the computations, or are you going from 1 hertz on up? I'm just curious if that's factored in as far as the dominant frequency, and if it includes sub-delta frequencies.
Well, we just follow what the brain does, so we can go sub 1, but if the brain is there, we'll see it. And we add the offset to that, and that's what becomes the feedback. So the feedback is always changing as the dominant frequency changes, with that constant of the offset added to it.
Could I apply my old lens and do a BodyLENS, or is it configured differently than the classic lens?
You're going to answer that before I know the answer. I'm guessing you can.
I guess I can, but has anybody done that, I suppose, would have been a better question. And what kind of results did they find? Or was that part of the experimental process?
You use a lens 1 for BodyLENS, but I don't see why you couldn't. Now, the new BodyLENS software has the names of the sites, like right upper shoulder, available to label the sites. If you use a standard classical lens, no matter what generation it is, 1, 2, or 3, you're going to be using EEG site names. And that's the only concrete difference I can think of. And the thing is that you can also, with the later versions, get more specific. If you're treating something with irritable EEG, or if you're treating something with very strong phase locking, which we call EEG suppression, you're going to be handicapped because you can't adjust the older versions the way you can the newer ones. So those are the two really big differences, I think, that strike me right now. There may be others, but those are the ones that strike me now.
Okay, great. Thank you. I'm planning to come back and get some more training. It just once I get some more clients and stuff, I'm sort of doing it on the side a little bit while I still work at the VA, which is
it'll be good to see
still
you.
not budging. Yeah, it'll be good to see you too. I'll look forward to that, Len. Thanks a lot.
All right, you're welcome. Bye-bye.
Hi, Len. My name's Adam. I just want to clarify that you're saying for the pain with the BodyLENS, 1 to 2 sessions at 109 seconds. Are you talking about kind of, are these exceptional results, or are you saying these are more normal and common to have pain resolved in that few of sessions?
Those are really typical kinds of results and not abnormal at all. There are exceptions to the typical results, but they are exceptions. So these results you're talking about are typical results.
Great.
There was a guy who was an IT person before he became retreaded as a therapist, and he entered the training with a great deal of back pain, having fallen on his feet, but he broke some vertebra, and a neurosurgeon tried to get all the pieces of bones out of the spinal cord, but could not. So he'd been in chronic pain for some decades, back pain. And, again, 109 seconds, pretty much, there may have been, I don't know, I wasn't there, more or less, but he said, oh, gee, I wish I'd had this done earlier, years ago, because the pain's gone. So we're not talking about trivial pain here. And it's always a mystery to me because nothing works for everybody. When it works and when it doesn't work. That's sort of a mystery to me.
Mm-hmm.
But I wouldn't believe anybody who said everything works all the time.
Right. And I was looking on your website, and it said that with LENS, with non-body talk LENS, you normally resolve TBI in 6 sessions, uncomplicated PTSD in 3 sessions. Again, those are typical results you're talking about?
They're a little bit over estimates, but they're close.
What would you say are more accurate estimates?
Maybe 5 sessions. And PTSD and anxiety situations are treated a little bit more rapidly than even TBI.
I can actually chime in, Len, a little bit. I don't usually work with that population as much as I did, but I had somebody coming in here that had 4 panic attacks a week, and within 6 sessions, she was gone. I mean, they had almost completely remediated, and again, this for me, again, Len's expertise, I think, still, no doubt, he has fewer sessions than I do, but that's like a miracle. And again, this doesn't happen all the time, but again, I'm not doing that population as much as I used to. But it's pretty amazing to see, and pretty wonderful, especially with the brevity of the sessions. It's phenomenal, really. I mean, I don't know anything like it that could do that. No medications. It's, what did you say the actual treatment time, Len, is like 1/100th of a second or something like that? So in less than a second of treatment, cumulatively, and she was very skeptical when she came in. Heck, I'm always skeptical.
I'm always skeptical. I still can't believe it.
So,
let me say something. I'm very uncomfortable with the LENS because I was trained in traditional neurofeedback and traditional biofeedback. And this is, it makes me uncomfortable. It's a surprise. It violates everything I think I believe. And so, I'm old-fashioned. It's hard for me to kind of let go of the old training. And for many people, it's hard for them to let go of the old training, the old procedures, the old constructs. It's really hard. And I'm known for my sarcasm and my dourness, and people say, "Get with it, Len. Come on, it's wonderful." And it's hard. I'm too old. It's hard for me to change, and I use the stuff, but it doesn't stop me from being skeptical. And let me talk about the word placebo for a change. And I know it was used in a different context before. Every engineer I've ever worked with who did programming and equipment design for me has said this stuff can't work. And they said, well, it could be placebo. And, no one comes to us as their first choice. They all try what's more conventional. So people have had many attempts to solve their problems, their chronic problems, whether it's pain or whether it's dysfunction. And if they've gone to many places and they've been adventurous, why should their pain all of a sudden clear up with us? And they had many novel treatments before and many opportunities to have placebos work for them before. But and even ours, we fail. I fail. We're only human. And I've seen some of my patients sitting in dental offices getting their teeth ground, and I was really depressed that that these people would show up seeking other treatments, that wasn't perfect. You know, so first I complain that the results are too good to believe. Then I complain when they're not perfect. So I get my way, and I always have a reason to be somewhat unhappy.
Len, this is John again. Are you using the sensitivity questionnaires the same way, or are there a different set of assumptions with these folks? I mean, I know all different kinds of sensitivities you can have, but wouldn't you say these folks in a way are sort of hardy? Because well, I have chronic pain. I have to sort of learn to endure it. We have to habituate to it to a certain degree, and you can begin to take quite a bit of pain before you really say, ouch, I need a pill. There are chemical copers, as they call them, who are more likely to look for a pill. But I think a lot of people I see sort of try to tough it out with the pain. So back to the question, what are you seeing with the sensitivity questionnaires? Anything different? Are you using any different criteria?
I'm using, we downplay sensitivity now. It's important as a discussion about what people's goals are and their resources and that kind of stuff, but not so much, we don't use sensitivity as a guide to sizing the session. We use instead the reactivity portion of that questionnaire in place of the word sensitivity. Because, you know, if a person's really sensitive and they're not reactive, then the feedback signals are just going to go into them and they're not going to react to them because they're not reactive. But if they're reactive, that then makes a difference and helps inform people about the duration of the session. And so in terms of using the reactivity scale, where 10 being the most reactive, it used to be that I considered the 0 of the reactivity scale as being the least reactive. I no longer do. I think it's a kind of a bipolar scale where there really are not people, if they're still alive, there are not people who are non-reactive. There are people who are covertly reactive, and they say, no, I answered that I'm not reactive, but I'm really reactive, and I just don't want to talk about my reactive. I don't want people to know how reactive I am. That's never worked out well. So even the people who respond like 0 on the reactivity scale, it turns out most of these people are at least covertly reactive. Or half the people are covertly reactive and half the people are overtly reactive. I had one guy who came in, he said, you know, I don't know why I'm here. If you want to know why I'm here, ask my wife. If you want to know how I'm doing, ask my wife. If you want to know when I should leave, talk to my wife. I know nothing. And halfway through, he said, you know, my wife says I'm coming home less bitter from the day now. But I don't know. So, you know, this business of reactivity and what's overt and what's covert is interesting. So the scale goes from positive 10, that's the most reactive, down to around 5, which I consider to be now the least reactive, and then down to 0, where you start getting more and more covertly reactive as you approach 0. So to deal with this, I have, with a piece of Scotch tape attaching this little scale to my wall in my office, I have a scale which goes from plus 10 to minus 10 through 5, and I then translate those numbers depending on what the person says. If I don't want anybody to know that I'm really reactive, so I'll answer 0. So if a person's 0, and clearly they're reactive, responsive, alive, then I'll put down, that they're very, very reactive. And the difference it makes is really what I focus on is just getting information from the patient that affects the treatment. I don't ask global questions that don't affect treatment. So if a person, say, is very covertly reactive and is erupting in the car, that's the kind of person that I don't want to have an eruption after a lens session. So I say, we're going to keep this very short because you're so reactive. That's his reactivity. That person's reactivity is what guides me to keep the dose minimal. Because if I do keep the dose minimal, then the reactions are not going to be a problem. And people will not be afraid to drive this person for another session. If the person erupts during the car, not only is that dangerous to everybody, including other drivers outside driving their cars, but the person driving the car will be really reluctant to take this person for another session. So I want to keep that session and that person's reactions minimized.
I have a question. This is Martin again. Do you have feedbacks from your client regarding how they perceive their sleeping?
We have questionnaires. We call it a top 10. So a person takes at the start, and this is if the professional wants to get this information. We have a CNS questionnaire, and we'll answer that. And from that, the top 10 ranked symptoms are extracted and are given on a weekly basis online. And then that goes into forming a graph, which we call a trend graph. So we can track the symptom intensity as time goes on. And we have statistics from a pool of, 13,000 patients. And when these questionnaires are given, and not everybody likes to give them, they really have a very good picture of the change, the size of the change in the symptom intensity as contrasted in relation to, and this is correlational, with the change in amplitudes during the session. And every measure of EEG that we have has a statistically significant change that is so high that it is labeled certain by the statisticians.
So if I understand, be aware I have not used or I have not concerned myself with your methodology, which is extremely interesting. I'm fascinated, I must say. So if I understand you correctly, what you're doing is you're making a client intake based on reported symptoms or goals they want to achieve. Is that correct? And then measure the entire progress on how they perceive their originally reported symptoms.
Well, we have both the subjective symptoms and we have the objective changes in the EEG.
Exactly, that's what you correlate, and that's an extremely interesting correlation. So,
and that is uploaded on every session given by the Lens to me. It is totally anonymous, so when I look at a session's data, I have no idea whose data I'm looking at.
Yeah, but the correlation, the ergonomic correlation between reported symptoms and what you report in neutral measured values, that's very helpful, I find. It's very far beyond treatment.
Yeah.
I'm impressed.
Oh, this is Rick again. I have a question. Do your frequency-specific effects, that is, the changes in this dominant frequency, are they predictable? Do they change in a predictable way? So, for example, when someone has pain, the dominant frequency decreases, or when somebody has anxiety, the dominant frequency increases?
If it's low at the start, it rises. If it's high at the start, it drops. So this is a kind of regression to the mean. And what we're doing really is simply recording and feeding back the information. It's almost like electronic meditation, where the meditator is taught to observe, but not to try to change the phenomenon. So we're just recording, and we notice that things change.
I see. So it's not really predictable in terms of symptomatology or anything like that.
It's pretty predictable, and not only that, but if we're looking at the raw EEG on the screen, whether it's BodyLENS or classic lens, the same things happen. The EEG gets less noisy and gets more compressed as time goes on. So we know that when we see a significant drop in the amplitudes of the recorded signals, and this is amplitude, and alpha tends to drop out, that the person is going to be experiencing something different. And generally about that time, they'll say, whew, boy, that's better.
Are you primarily training with eyes open or eyes closed?
Certainly eyes closed, because what we want when we train from the front of the head, we want to soften the muscle contractions around the orbits, within the orbits of the eyes, the extraocular muscles. So we don't want that to contaminate the EEG signals coming from the front of the head.
Yeah, that makes sense. Thank you.
You're welcome.
Just a footnote around that. With autistic children, you're not always able to get that, and it still works. So just to let you know.
Yeah, and that's why I think that the lens and the BodyLENS are particularly good for children, because they do tend to move around. They tend to keep their eyes open. I mean, even if we give them a teddy bear and say, look down, turning the eyes down to the teddy bear in the lap is one way to quiet the muscles, but even then the children won't do that.
Mm-hmm. And the brevity is, I mean, Len, you have made neurofeedback available to thousands of people that wouldn't be able to do it, because the brevity of the treatment for these autistic children, as well as, by the way, the parents who are completely exhausted, they're thrilled to come in. When I first started, remember, Len, your treatment was 30 seconds, and then you brought it down to 10 seconds? And I said, thanks a lot. My parents already thought I was a fraud at 30 seconds. And but they love the brevity of it. I mean, I'm only teasing when I say my parents thought I was a fraud. But when I was first starting, and you're charging X amount of money for a 30-second treatment for their child, and then Len says, let's bring it down to 10 seconds because we're getting some filtering difficulties or whatever it was. But truly, he has brought neurofeedback to the world in a way for these children that a traditional session could never do. These children could never sit still, or very rarely could sit still for a 35-minute traditional session.
And just to keep people from saying, Len said that less is more, there are people that we give extremely long sessions for, and we're talking 10, 20, 30, 40, 50 minutes, as much as time there is in the session, and they benefit from them. And they're the people specifically who don't know whether they're improving. They just don't know. So at least they can feel tired, which they call themselves relaxed, which is achievement for them. And Kathy has a habit of saying to people who don't like the ultra brief sessions, she says, if you go to an ER with a speck of glass in your eye, do you want what are you going to say when the physician says, do you want me to take 40 minutes to take this speck of glass out, or do you want me to just take it out in a split second? You say, I want the short one. So brevity has one meaning in the mental health field of being a sham, and another meaning in medicine, meaning ultra competent.
the other thing is, after the first treatment, they become believers, first or second treatment. I don't always get a change after the first treatment, but it's pretty rare that I don't get something after 3 treatments. A story. They come back with a story. As a matter of fact, I had to come up with a new category called the nevers, because they say, this never happened before, this never happened, so I actually have a category called the nevers.
A category of diagnosis called competence. There are people who use competence to achieve what they achieve. They're very bright people, and they have developed skills that are so rigidly developed they can't adapt. So that and people love the diagnosis of competence.
So Len, what are we looking at here? I know it's past 8. And I'm sorry to. Are we looking at the BodyLENS equipment?
Yeah, it's the same.
Okay.
It's the same equipment.
Okay. Oh, the same equipment as. Oh, is that a lens? I'm still back and. Okay, that's the LensWear 3.
Yeah.
Or 4? I'm sorry.
3.
Not 4. 3. Yeah. Okay. Gotcha. It just looks different than obviously what I. Okay, Len, thank you for everything you have done, literally, for the world.
Hang in there, Don.
Okay. My pleasure.
It really is the therapist's skill that really brings out the best in the lens or the body lens. And it's important that people, I think, become licensed and become trained and supervised. That's where people really pick up enormous amounts of skill. And I admire the people.
Okay, Len.
Where can somebody hold one real quick question?
Sure.
Where can someone get a list of lens providers?
Right on the OchsLabs website at www.OchsLabs.com. Click the provider search, and you'll see that there are U.S. providers, Canadian providers, and international. We're in about 27 different countries. And the ability to be listed on the provider list is strictly a voluntary thing. People still walk around, some people in trench coats with their collars up when they don't want other people to know they do the
Okay.
Well, Len, thank you.
Rob, you made it. Good.
Well, I've been listening on silent. Yeah, it was my computer. I'll tell you about that all later. But
voices of the station at the 9.
So thank you so much for your time, Len, and presentation. Excellent. And we'll be in touch with you soon.
I would love to do this again, so let me know.
Yeah, thanks
Alrighty.
very much, Len. We really enjoyed it. Take care.
And for those listening, we are not going to be